So the treatment landscape for CLL is really evolving, and I think there are probably some provincial differences. Within my own clinic currently, for younger patients with untreated disease, as long as they don't have any significant comorbidities, we're still using FCR as the primary therapy. For older patients, we primarily use BR. And we have limited access still to Ibrutinib in the upfront setting, with the exception for the 17p deleted patients. This study that was just presented it really is a groundbreaking study that I think will be practice changing. We know that the novel drugs that have emerged are seeking to replace standard chemoimmunotherapy, and this is a trial that everybody's been waiting for a long time, which was the head-to-head comparison of FCR versus Ibrutinib and rituximab in a younger FCR-appropriate patient population. So the primary endpoint of the trial was progression-free survival, and that was markedly improved for the patients receiving the Ibrutinib and the rituximab. Importantly, at this interim look, they actually also managed to demonstrate an overall survival advantage, which really was quite marked. I think the presentation was quite interesting because they further dissected the progression-free survival according to IGVH status, and what seemed clear is that a large amount of the benefit was driven by the unmutated CLL patients. So going to safety, I guess globally, I have to say that there was less toxicity with the Ibrutinib and the rituximab overall, and that they had less grade 3 to 5 adverse events. Although they did make a comment that they did see a heightened increase of adverse events, in the slightly older patients in their population compared to the younger patients in their population. Yeah, I'm glad that was actually asked because it wasn't addressed in the presentation itself. Of course, based on the trial design, you can't answer that question. So the Ibrutinib arm in this trial contained the rituximab. So, but what we did learn from another trial presented here, which was a comparison between BR, Ibrutinib alone, or Ibrutinib or rituximab, and in that trial, the rituximab didn't seem to add anything. So I think it'll be interesting to see how people extrapolate across these two different trials and what standard is taken forward. I think across both trials that were presented, so namely the one we just saw in the late breaker that compared FCR and IR for younger patient population, and the one that was presented sort of several days ago looking at Ibrutinib IR versus BR in an older patient population. I mean, the similar message emerged that the use of Ibrutinib early in patients does seem to offer a really big advantage in terms of progression-free survival, and now from today's presentation, overall survival. So I think it's inevitable that Ibrutinib is going to place itself as frontline therapy probably for all patients with CLL. And I think, sort of extrapolating across trials, it'll probably be without rituximab. It's going to have huge resource implications to a certain degree, although, I have to say that we're already all using Ibrutinib. It's just in the relapse refractory setting. So there will be some immediate implications where if we land up moving this forward to the majority of patients, this is meant to be given indefinitely. But I think that in the bigger picture, most patients with CLL do need to go on to secondary therapies. So it really is a matter of repositioning where it goes.